Good evening all and welcome to this session on the High MCQs. As discussed last time, we have started the series on the High MCQs region wise. So today we have started with the head neck part 1. So tomorrow there is going to be a part 2. Same time around 10:15 p.m. We are going to discuss around 10 to 15 high MCQs daily with the region wise. Hello and welcome all. My name is Dr Ankit Khandelwal, MBBS MS Anatomy educator in Unacademy. Let's start the session. Here we go. So today is the first day in head neck part 1. Here we have this whole week of April free test calendar. This is the Unacademy Lite and its various features, the test series and all those mock test papers over here. It is MBBS Prof 1 batch which you can enroll, started on April 20th. And you can use the code. The code is Dr Ankit Live. The code is Dr Ankit Live to get some discounts if you wish to. Every educator has a code. My code over here is Dr Ankit Live. Next, we have this slide which is showing you the practice papers, daily practice papers with plus classes. This is a doubt clarification batch which has just started on the early part of the April. Special class features. Special class also, we're going to have alternate special classes. One special class I conducted yesterday on the topic of the shoulder joint. Tomorrow we are going to have a special class. The time will be around 4:30 in the evening. The topic is going to be the craniovertebral joints. These are special class features. Educator revision batch over here, foundation batch. These are all the batches, and that is your some discounts going on right now, which you can get used to it. 3 types of subscription: Unacademy Plus, Iconic, and Unacademy Lite subscription. Let's come to the topic. The topic is high MCQs, head neck part 1. So here we will be having MCQs of head neck obviously, and I will be giving you some time. You have a comment box. You can just write A, B, C, D. When you are asked to answer on any particular question, you can input your response over there, and we'll have a brief short discussion on that MCQ. Let's start with the first MCQ over here. This is the first MCQ. I'll read out the questions and the options. The question says a 26-year-old man comes to the physician for the follow-up examination. 2 weeks ago, he was treated in the emergency for head trauma after being hit by a bicycle while crossing the street. Neurological examination shows a decreased taste on the right anterior tongue. So that is a feature, that decreased taste on the right anterior tongue. This patient's condition is most likely caused by damage to a cranial nerve that is also responsible for which of the following? Okay, that is also responsible for which of the following? Options are uvula movement, option A; option B, facial sensation; option C is eyelid closure; option D is a tongue protrusion; and option E is a parotid gland salivation. First, we need to know that which cranial nerve is this, and if we know the name of that nerve, we can see what are other functions of this nerve, and one of them should be out of these 5 options. So, waiting for your responses, guys. And I guess we have some responses which have started to come. And first response is option number C, I guess. So yes, what is the nerve over here? Decreased taste on the right anterior tongue. So total anatomy question, if you look at the tongue also, anterior 2/3 of the tongue, the taste is carried by the cauda tympani nerve, a branch of 7th nerve. Taste. General sensation are carried by the 5th nerve. Okay, the lingual branch of the mandibular nerve, that is the 5th nerve. But taste is carried by a cauda tympani and branch of facial. Now, uvula movement, that is the motor supply of the uvula. Uvula is a part of soft palate, and the muscles of the soft palate are supplied by perineal plexus. So the 10th nerve is over here, right? Second option, facial sensation of the face, 5th nerve. So nerve number 5, but that is not the taste. That is a general sensation for the tongue. Eyelid closure of eyelid. Closure of eyelid is done by the muscles which are surrounding the orbit, orbicularis oculi. Facial muscle supplied by facial nerve. Tongue protrusion is done by the genioglossus muscle, and the nerve supplying it is the hypoglossal nerve. And option E, the parotid gland salivation. Salivation, that is the secretomotor fibers of the parotid gland, are coming through the otic ganglion. So there is a postganglionic fibers of the otic ganglion which are basically our auriculotemporal nerve. And this auriculotemporal nerve is a branch of 5th nerve basically. So again, this is 5. So we have to look out for the 7th Out of these, option number C, that is the answer. This is the answer, that is the eyelid closure. I hope point is clear. Yes, some of you going with C, some of you going with E's. So for those who are going with E's and other options, if that is running in your mind, I hope the point is clear. Tongue, taste, seventh nerve, anterior. Out of these 5 options, seventh nerve is involved where? It is involved in option number C, eyelid closure. Orbicularis oculi muscle, eyelid closure, right? LPS, opening of eyelid. Levator palpebrae superioris, third nerve. Okay, so eyelid opening is by the third nerve and closure is by the facial nerve. Okay, got this point? Suppose one more hint over here, the corneal reflex. If you remember the corneal reflex, when we used to study the corneal reflex, what we used to do was, in this test, we used to put a small wisp of cotton on the side of the cornea or the conjunctiva, and there was a tight closure of the eyelids, right? Afferent for this reflex is by the nerve which is carrying the sensory from the cornea conjunctiva, that is basically ophthalmic division of trigeminal. Remember? Efferent is basically efferent is this closure of the eyelids. Seventh nerve, facial nerve, orbicularis oculi. I hope now the point is clear, right? So first question, option C is the answer. Let us move to the second question over here. The second question says that a 1 month old boy is brought to the physician by his mother because of a 2-week history of persistent watering of the eyes. On physical examination, palpation of the lacrimal sac causes tears to leak from the lacrimal punctum. So if you remember that there is a lacrimal punctum openings, then there is a canaliculi, then there was used to have a lacrimal sac over here. Punctum is an opening, canaliculi is small canals, and this is a sac. So this said that palpation of the sac, tears to leak from the lacrimal punctum. So when you palpate the sac, tears came out from the punctum. Physician concludes that the most likely cause of the patient's symptoms is the congenital obstruction of the duct. Remember, there is some duct which is going down and there has to be some obstruction of it. Fine. The duct that is most likely obstructed in this patient drains into which of the following structures? So this is a duct. Drains where? Normally in yours or my system, where does this duct normally drain? Options are inferior nasal meatus, sphenoethmoidal recesses, pharyngeal recesses, or the middle nasal meatus. So I hope the question is not that difficult, and as we can see the options are coming, yes. The duct is the nasolacrimal duct. I hope you all know about it. This is the nasolacrimal duct, opens into the inferior nasal meatus. Answer is option number A over here, that is the answer, right? Nasolacrimal duct. This got obstructed, newborn child normally happens, you do a lacrimal massage, there are various investigations, normally this massage and all, it may open up in some time. But yeah, this whole thing. Now, the other questions that can come from the NLD is, what is the direction of NLD? Obviously, it is downward now. That we all know, it is going downward. But is it going forward or backward? Does it go medially or laterally? So do remember, the sign for pound is LB. It is going laterally and backward. It is downward obviously, but also laterally and backward. Now this question has been asked. The direction of the NLD. It is downward, laterally, and slightly backward. Okay, I hope the point is clear. It's a straightforward question, right? So we move to the next one. Yeah, if we look at other options also, you can look at other options. Sphenoethmoid, this is the superior, you can say not superior, basically the sphenoidal sinuses, sphenoidal air sinuses normally open over here. Pharyngeal recesses are basically present in the nasopharyngeal wall posteriorly. And middle nasal meatus, basically the maxillary sinus, the frontal sinus, these are the ones, and the anterior ethmoidal sinuses, these are the ones which normally open into the middle meatus. But NLD opens into the inferior meatus. Let's move forward to the third question, and here it comes. Question says a 23-year-old lady comes to the physician because of 2-month history of episodic headaches associated with dizziness, nausea and vomiting. So, young woman, 2-month history of episodic headaches with dizziness, nausea and vomiting. Fine. Over-the-counter pain medications have failed to reduce her symptoms. Now, OTC drugs are very common in India, we all know, and yeah, that didn't made an improvement. MRI shows the isolated dilatation of the left lateral ventricle. Isolated dilatation of the left lateral ventricle. Okay. This dilatation is most likely caused by blockade of which of the following structures? Is it the arachnoid villi, interventricular foramen, median aperture, lateral apertures, or cerebral aqueduct? That is the question. So MRI has to be conducted in this lady to figure out what is the reason for her pain and all that. It could be a migraine and all, but yeah, MRI was conducted and something came out. What is the option? What is the correct answer? What is your take, guys? Out of these 5 options, isolated dilatation of the left lateral ventricle. Now this ventricle is not a ventricle which we use in different areas, but this ventricle is the ventricle of the brain. It's a fluid filled space having CSF, cerebrospinal fluid. What is the answer? Let me see if you have started answering. I'm going in E's and B's. Okay, let us see. Fine. Let us come to the whole understanding of this question. We normally have two lateral ventricles. If you look from above, there is one lateral ventricle for each of the cerebral hemisphere. 2 lateral ventricles. Both of these lateral ventricles, they open up into the third ventricle, which is a midline unpaired structure. That is the third ventricle between the 2 diencephalon with the third ventricle. And this third ventricle, it will go down with a very thin aqueduct, and that will open up into this fourth ventricle. And this is the normal flow chart. I repeat, these are the lateral ventricles. This is the third ventricle, that is aqueduct of Sylvius, that is the fourth ventricle. Clear? They all have CSF, that normally flows. And they have inside, most of them have choroid plexus which secretes CSF. CSF flows in them. Now see how does it flow. Between the lateral and the third ventricle, you have the interventricular foramen of Monro. I'm just writing MON, so you know Monro. Connecting third to the fourth is aqueduct of Sylvius, that runs in the middle brain. Fourth ventricle is between the cerebellum behind and pons and medulla anteriorly. So it is basically, we can say, a cavity of the hind brain. There is midbrain, hindbrain and forebrain. They said in the question that there is isolated dilatation of the left lateral ventricle. So this, let us say this is the left side, this one got dilated, that was fine. And the dilatation would have been pressing on the brain because it was a 23-year-old lady. And outside we have this skulls, and between the brain got compressed and the lady got those non-specific symptoms of headaches and dizziness, nausea and vomiting. So this thing will be dilated once the obstruction is over here on the one-sided interventricular foramen of Monro. So if you come back to the options, then this is the correct answer. So I guess those going with the option number B, that is correct. This is the correct answer. Now arachnoid villi is, what about option A? This is present in the superior sagittal sinus. Okay, the superior sagittal sinus, and there the CSF gets absorbed in the superior sagittal sinus. From all those areas, CSF comes and it gets absorbed through the arachnoid villi. Median aperture and lateral apertures are those apertures found in the fourth ventricle. Because from here the CSF will start to drain out into the subarachnoid space. And cerebral aqueduct we have seen connecting third and fourth ventricle. Now imagine if the cerebral aqueduct was blocked or the apertures were blocked. That would have led to bilateral dilatation of the lateral ventricles, not isolated to any one side. Okay, if any one of these parts would have been blocked, there would have been a bilateral dilatation of both the ventricles, not only one side. So therefore the answer is straightforward, interventricular foramen of Monro. I hope the point is clear. Let's see the next question. The next question says that a dislocation of the jaw, displacement of the articular disc beyond the articular tubercle of the TMJ. I repeat again, dislocation of the jaw, displacement of the articular disc beyond the articular tubercle of the TMJ results from the spasm of or excessive contraction of which of the following muscles? Options here goes like buccinator, lateral and medial pterygoid, masseter and temporalis. Let us see what is your take on it. What answer do you guys think? Yes guys, answer. We have some time. Shikha has started answering with, let us see what others think. So there is some jaw dislocation of the jaw, involvement of articular disc, and they are saying that there is some contraction of some muscle which has led to the pulling of the disc and leading ultimately to the dislocation of the jaw. Which muscle out of these has a direct connection with the TMJ and the articular disc would be the best answer over here? Yes, most are going B's and B's. Let us see what is B option. Lateral pterygoid. Perfect over here. Lateral pterygoid is a big muscle. It's a huge muscle, and that when it converges close to the neck of the mandible. So here you have the head of the mandible, and the neck and all that. You have this different processes, and this muscle goes, and continuation of this muscle will also be attached to the articular disc. This will be a big muscle over here and goes to the articular disc. So articular disc is said to be a degenerated tendon of the lateral pterygoid muscle. So normally dislocation of jaw happens when we open the jaw in surprise, like some shocking news came and like this. So sudden opening of the jaw, and opening of the jaw is a feature of this muscle. So it is sudden contraction of this muscle. When sudden severe contraction of this muscle, it could pull the tubercle and along with it the head of the mandible anterior to this, what we can say, the articular tubercle. So it is not coming back. So mouth is open like this. Now with the simple manipulation, with you keep your both the hands, the thumb on the side of the lips and the forefinger on the angle of the mandible, you pull it above and back and then you fix it. It can be done after giving some local anesthesia if needed. So yeah, lateral pterygoid is directly related to the articular disc. Dislocation of the jaw, it has a direct relation to it. Fine. So I hope the point is clear. Let's see the next question, the fifth question over here, which goes like this. Here is a picture, we'll see this. But read the question that examination of the newborn reveals the craniofacial defect seen in the photo. In this case, the defect is related to the failure of fusion of which craniofacial process? Have a look at the pic. Look at this pic of the child. And there's an abnormality which you can see in this pic, and you have to figure out that it is due to failure of fusion of which processes. Theoretically, which processes failed to fuse led to this. Options are maxillary and medial nasal process, opposite maxillary process, medial and lateral nasal process, maxillary and lateral nasal process, or opposite medial nasal process. Different options are over here. Choose the best answer. Let us see. Sameer has started answering, and let us see what is the correct answer. I hope I should stand over here so that you can see the pic and the options both. Have a look. Saw the pic, I guess. Now the options, you can have a look at the options, and I can look at your responses. A's and D's. Most of you going with A's and D's. First option, fourth option. What is first option? Maxillary and medial nasal process, and the fourth option is maxillary and lateral nasal process. Okay, what to do? It is a single best answer question. You can't have two options. Let us understand. Let us understand for a while. What happens is, we should be knowing that in this face, if we look at the nose over here, right, and the upper lip over here, and let us understand the orbital area is over here, the ears are on the side, fine. But which processes are forming what structures? Remember the lateral nasal process, it forms the side and ala of the nose. This is our what? Lateral nasal process. Which process? I am writing over here LNP, lateral nasal process. Upper lip over here is found in the middle part by the medial nasal process, which actually is from here, medial nasal process, which also forms the crest and the tip of the nose, along with the bridge, crest and tip of the nose, goes till the middle part of the upper lip. That is medial nasal process. The maxillary process, this is the maxilla bone, I hope you all know that this is the maxillary process area, and it joins the medial nasal process to form the upper lip. So upper lip is basically formed by, if you solely take the upper lip, this area, by the medial nasal process and the maxillary process. Now if you look at the image over here, the child problem is basically in the upper lip. This part of the upper lip is formed by the medial nasal process, and this part was formed by the maxillary process. And you can see they are not fused over here. For those going with option D, that is maxillary and lateral nasal process. Lateral nasal process is fine over here, maxillary is fine over here. So if there was, that is a very, very rare abnormality, both the nasal processes are not fusing, that is a very rare thing. If that would have been the case, there would have been some problem over here in the nose part. But here the problem is the lip part, and lateral nasal process does not contribute to the upper lip. It only forms the side and ala of the nose, that's it. The lateral nasal process does not contribute to the formation of upper lip. Therefore, the answer over here is option number A. So, those going with option number A and those thinking of it as the option number A being the answer are correct over here. Even if you are not answering in the comment box, fine. If you are thinking option A, fine. But if thinking any other option, then obviously you can correct it. Okay. So, understand now, if the question comes like, find that maxillary, let's take this option only, maxillary and lateral nasal process. When these don't fuse, what will happen? Look over here that this was the maxillary process and that is the lateral nasal process, right? This is our option number D. If these don't fuse, there will be a fissure over here. It will be going from side of the nose to the middle canthus of the eye. That would have been the fissure. We call this as the oblique facial cleft. What do we call it as? We don't call it as a cleft lip, or this is actually a unilateral cleft hair lip. But this non-fusion of maxillary with lateral nasal process, oblique facial cleft. And the NLD which we read just a couple of questions back, the nasolacrimal duct. When these processes will not fuse, this will be opened up. The NLD is opened up. The nasolacrimal duct is opened up over here. So remember that part. Oblique facial cleft. Okay. Let's see the next question, and this was the fifth one. Let's see the sixth one over here. Which one of the following nerves, okay, carries postganglionic parasympathetic fibers to the parotid gland? I hope if you are listening very carefully, I have just discussed it 10 minutes back. Auriculotemporal, glossopharyngeal, axon carotid plexus, or facial nerve, which carries postganglionic to the parotid gland. There is a ganglion, there is a preganglionic, there is a postganglionic, and this is your dear parotid gland, right? Let's see what you guys are thinking. Yeah, Tilly, very good. Do you remember that? Good. I said, no, just 10 minutes back in discussing some other question, we discussed that. Yes, so this is the ganglion, that is the otic ganglion over here, and parotid gland. This postganglionic is auriculotemporal nerve, a branch of mandibular division of trigeminal. But if they ask you, suppose this post goes from post to pre, what is your answer now? If the post, write in the comment box. If the answer, if the question changes from post to pre, which has the preganglionic nerve to the fibers of the parotid gland, now what becomes the answer? I am waiting to see your answers. Preganglionic nerve to the otic ganglion. From where does it come? It comes from the brain part, but which part of the brain? And which is this nerve? Yes, option number B, and I hope B is right, glossopharyngeal. Perfect. So this is a medulla oblongata part of the brain stem. You have a salivatory nucleus over here. Tell me which salivatory nucleus, inferior or superior salivatory? One of them has to be the correct. It is inferior or superior salivatory nucleus, and this nerve is basically the lesser petrosal nerve branch of glossopharyngeal. But which salivatory nucleus, that you can answer over here. Someone wrote yes, not a question mark. You are perfectly correct over here. This is the inferior, not the superior. Superior one is for the seventh nerve. This one, the lesser petrosal nerve, that is a inferior salivatory nucleus. Inferior salivatory nucleus, right? Remember this part. Answer, but this question, post is auriculotemporal. If it becomes pre, we know this, and other things also it should be. So basically, the thing which I wanted to stress over here is the topic of the parasympathetic ganglia of head and neck. Four major parasympathetic ganglia: ciliary, otic, pterygopalatine, and submandibular ganglia. You need to know what is the pre and post ganglionic and where it is going, where it is relaying basics, and where are these ganglia actually located anatomically, right? Just that. So this topic is important. Let's move to the seventh question, and long question, don't worry, we'll just read it out. A 76-year-old man is brought to your office, any clinic or hospital, by his wife because he keeps running into things. He keeps running into things on his right side. His wife also states that he seems to ignore objects on his right sides. So there is a problem on the right side of the patient. You test his vision in each eye and determine that your patient cannot see anything in the right visual field of either eye. So that is a finding now. His complaint is a finding. You order a head MRI because you suspect which of the following? So you're suspecting some of that. Option number first is pituitary tumor compressing the optic chiasm. Option number second is tumor in the medial wall of the right orbit compressing the optic nerve. Option number C is aneurysms of the left middle cerebral artery compressing the left optic tract. Option number D is a tumor in the middle cranial fossa compressing the right optic tract. These are the 4 options. And let us see what you guys are thinking about the answers. Yes, very good, very good, very good, very good. Couple of responses and a really good one responses. The patient is not able to see anything on the right side of it. Okay. Therefore, yes, very good. Let us now see. The answer is option number C, third option. Aneurysms of the left middle cerebral artery compressing the left optic tract. Just remember over here, the person was not able to see things to the right side of it. If you just imagine the eyes over here and the right and left eye, things on the right side patient is not able to see. Simple optics, the rays will fall on this part of the retina. So what we can say is that the left side temporal hemiretina and the right side nasal hemiretina, they are not able to function. And if you trace them, okay, if you trace them, then this will go on the same side and this is actually going to cross. They will both become the left optic tract. So remember, in the left optic tract or in any lesions of the optic tract, just remember this basic point. If there is any lesion in the optic tract, the visual field loss is always on the opposite side, contralateral, homonymous hemianopia. Just remember this point, contralateral homonymous hemianopia. Contralateral lesion in the left optic tract, person is not able to see things on the right side, contralateral. Homonymous, why? Because the direction of the visual field loss is same. Why hemianopia? Because half of the retina is involved, the other half is perfectly fine. So see how the patient will come to you, that he keeps running into things on his right. Suppose there are 2 pillars over here and I am walking, and so patient is walking, he is not able to see anything over here. He will be banging his or her shoulder to the right side. The things which are placed in his home or house, he will not able to see them, and his hand will be some bruises could be over there. So these things, the patient or the relatives of the patient will come to you with this sort of thing. Okay. So remember, contralateral homonymous hemianopia. Let's see the 8th question now. 32-year-old man presents with a unilateral paralysis. Unilateral what? Paralysis of the muscles of mastication on the right side. This condition has resulted in facial asymmetry. Though he is uncomfortable with this appearance and has difficulty when chewing his food, obviously when there is masticatory muscle paralysis, there will be problem in the chewing the food, fine. But the chief complaint is his difficulty swallowing, dysphagia. The chief complaint is not the look, chief complaint is not he is having difficulty in chewing, because still half of the mandible, half of the masticatory muscles are working, so he can chew on this side, fine. But the main problem of this patient was he is having difficulty swallowing, having dysphagia. Now they ask you what muscle is likely involved in causing this dysphagia. Okay. Philtrum is formed by frontal nasal process or medial nasal process, confused. Frontonasal process basically from the forehead. Philtrum over here, right from here to here, is all about the medial nasal process. Okay, just your query over here in between. Okay, so fine. This part, and not just this, going to the primary primary palate. This part over here, the triangular part, intermaxillary segment, that is also medial nasal process. It is a direct continuing line. Now come to this question. He had paralysis on the masticatory muscles on the right side, but now having dysphagia. Which muscle? Options are sternohyoid, stylohyoid, cleothyroid, stylopharyngeus, or mylohyoid. Let us see your responses. D's, and D's. I guess D's is for this question only. D was this. No, okay, this question. What is D? Stylopharyngeus. Fine. Now, let us see the question. Which nerve is involved? If you look at the first line of the question, paralysis of muscles of mastications. Muscles of mastication are supplied by mandibular nerve. I hope there is no one will complain by this statement. We all know. Then he is saying all of that and difficulty in swallowing. Now, out of these 5 options, which muscle is supplied by mandibular nerve? Let us see. Sternohyoid by ansa cervicalis. Okay, stylohyoid by facial nerve, cricothyroid by vagus branch, mainly the external laryngeal nerve, branch of superior laryngeal nerve, stylopharyngeus by ninth nerve, mylohyoid by fifth nerve. That is a V3. Now, out of these 5 options, only one option is being supplied by mandibular nerve. So, why not option E? Because you thought that, okay, swallowing is only pharynx, so let us go with pharynx, but aren't you seeing that V3 has nothing to do with the stylopharyngeus? Yes or no? If there was a ninth nerve problem, supposedly, then problem would have been different. Gag reflex problem, aspiration problem, tongue sensory, posterior part of the tongue sensory issues, taste issues over there. Problems would have been different. Yes or no? But here the problem is difficulty swallowing. And just tell me, if you look at the whole pharynx, pharynx has a lot of constrictors, the superiors, the middle, the inferior, this form the bulk of pharynx. Then you have small muscles like palatopharyngeus, stylopharyngeus, salpingopharyngeus. Out of them, one is stylopharyngeus. And can you think that ninth nerve, which has nothing to do with the masticatory, suddenly will come and denervate stylopharyngeus and there will be dysphagia? Why? What has fifth nerve in relation to ninth nerve? Is there any? No. Only option which is supplied by fifth is mylohyoid. But how can mylohyoid produce dysphagia is now the main point which may be disturbing to you. First of all, let me tell you mylohyoid why. V3 supplies all the masticatory muscles that we all know, but what we all should also be knowing that it also supplies 4 extra muscles. The mnemonic I have told multiple times is MAT. M refers to mylohyoid, A refers to anterior belly of digastric. These 2 T's are 2 tensor tympani and tensor palatini. Remember this. Now come to the swallowing part. How can mylohyoid paralysis produce dysphagia? Where is mylohyoid? It forms the oral diaphragm. It forms the oral diaphragm. Where is oral diaphragm? Over here. Over here, just inside. If you put your hand over here, then this part is the mylohyoid. Now put your hand over here, all of you, and try to swallow. If you are feeling any movement over here, then this muscle is acting. Agreed? Mylohyoid. What does mylohyoid mean? Mylohyoid meaning it is going from, hyoid is the hyoid bone, mylo is mandible. When we swallowed, doesn't our hyoid bone moves? Larynx moves. The hyoid bone is lifting up the whole larynx. This is moving. Mylohyoid is moving. In the question it said, problem was in, not in inability to swallow, problem was a difficulty. Now when this muscle is paralyzed, this thing will have some initiation. The first stage of swallowing will be there will be some difficulty without a doubt. Answer is mylohyoid. Agreed? How mylohyoid could lead to difficulty in swallowing? Not inability to swallow, but difficulty in swallowing. Fine? Stylopharyngeus will not do that. It's very small, thin muscle compared to if you look at the whole pharynx. Okay, so this question answer would be mylohyoid, right? Let us move to the 9th question. 43-year-old lady came with a large abscess in the middle of the right posterior triangle. So this is my right posterior triangle. It's SCM trapezius. This is the right side posterior triangle. This lady had an abscess. Okay, the physician incised and drained the abscess. IND abscess, we all know IND. We read it in surgery all the time. 5 days later, the patient noticed that she could not extend her right hand above her head to brush her hair. What could be the cause? This is a very old and not very old, but little bit old question and has been multiple times repeated. Now, the lady said this statement is a big thing, but in practical life, I'm telling you, if there is a patient who came to with abscess over here and you drain the abscess, and after a few days, the patient noticed in his or her house that they're having problem in brushing their hair, they won't ever think of this problem related to this. Because this brushing their hair is all about the upper limb. And what you drained or incised in the hospital 4 or 5 days back was this. So what is this to do with this? Nothing for a patient. But for you, it has a lot of thing. And what is a lot of thing? C's and C's. Let us see what to see. Cut the ear. So you can see the options also, because I didn't read the options, but you can see damage to scalenus medius, injury to suprascapular nerve, cut to the spinal part of axillary nerve. That is the answer. Because here you have in the posterior triangle, you have the spinal accessory nerve, which supplies these 2 muscles, trapezius and sternocleidomastoid. So it supplies two muscles, the trapezius and sternocleidomastoid. Anatomically, it is in the posterior triangle of the neck. So what about this? This trapezius, along with the serratus anterior, does the overhead abduction. Now brushing the hair, you need to abduct your hand more than 90 degrees. That is the point. Therefore, trapezius would have been some problem, and this would be the answer over here. Right? Very old and a very oftenly repeated question. Just remember this question. Let us move to the 10th question now. And the question says a baseball player was hit in the base of the skull, by a loose bat. Baseball player, loose bat. He is hoarse and complains. Hoarse means hoarseness of voice, and complains of difficulty swallowing. Hoarseness of voice and difficulty swallowing. Okay. The X-ray indicates a basal skull fracture that passes through the jugular foramen. If the nerves passing through the jugular foramen were severed as a result of the fracture, which of the following muscles would remain functional? Fracture, nerves got injured, foramen, jugular. Which muscle would remain functional is what you guys have to figure it out. Answer. Yes, think and answer. Let me see your options over here. Okay, we can see some option. Let me read out the options to you. Palatoglossus muscle, sternomastoid muscle, styloglossus muscle, stylopharyngeus or trapezius. I guess you guys have started answering. Okay, A's and D's are coming. You are going with C also, I guess. C was for the previous question. Let me see. Previous question, yeah, P. Okay, previous was C. For this question, I answer. A's and D's have come till now. Palatoglossus, so jugular foramen or jugular foramen, present at the close to the base of the skull. The nerves that are passing through jugular foramen are 9th, 10th, and 11th. That is what we should know. Basic of head and neck. Cranial foramens. They are asking you which muscle would remain functional if these nerves are damaged. Palatoglossus, muscle of the tongue also, muscle of the soft palate also. Supplied by which nerve? Supplied by the 10th one, plexus, pharyngeal plexus. Sternomastoid, we just saw, 11th nerve. Styloglossus, tongue muscle supplied by 12th nerve. Palatoglossus is an exception. It is also palatal muscle. Palatoglossus is also a palatal muscle. I guess we got the answer. Answer is styloglossus till now, but let's see the other two options. Stylopharyngeus we have done tonight that it is 9th and 9th nerve. Trapezius again is the 11th nerve. So 9, 10, 11. Answer is option number C. I guess we all agree with this, right? So I'm going with the D's and E's also. I hope the point is clear. For the hypoglossal nerve, we have a separate hypoglossal canal. Okay. 9, 10th, 11th is jugular foramen. Fine. I hope the point is clear. Okay, let us do a couple of more questions. Glossopharyngeal vagus spine exercise. Yeah. A couple of more questions. Will that work? Let us do. Let's come to the 11th question. Green color. The smallest question till now. Green color, I don't know whether you are able to see it nicely or not, but I will read out the options. All are supplied by ansa cervicalis except. Options are thyroid, sternothyroid, sternohyoid, or inferior belly of omohyoid. The smallest question till now. Tonight, smallest question is this. Topic is important, ansa cervicalis. Answer for this question is yes. Ansa cervicalis, all are supplied by ansa cervicalis except A, B, C, D. This is your carotid sheath, and here you have this ansa cervicalis. Here you have the anterior triangles. So it sends the nerves to supply the strap muscles. This ansa cervicalis is a loop which is contributed by the 12th along with the C1 and C2 and C3 over here. They form a loop of nerve, which gives out the branches, supply the muscle in the anterior triangle, which has a muscular triangle, which have the strap muscles. But all these are strap muscles only. Thyroid, sternothyroid, all these are strap muscles. What would be the answer? Yes. What happened, Aishwarya? I didn't get you. Any issue? B's or A's? B's and A's are coming over here. So remember the ansa cervicalis. Ansa cervicalis will give the branches to the strap muscles. The mnemonic of that is, remember, omohyoid, sternohyoid and sterno. That's it. You used to remember it by mnemonic. Oh, she is stunning. She looks very graceful. Oh, she is stunning. Omohyoid, sternohyoid, sternothyroid. Omohyoid, sternohyoid, sternothyroid. This is not supplied. Being a strap muscle, thyroid is not supplied by ansa cervicalis. That is what we need to answer in this particular question. But then the question should come into your mind is, then it is supplied by which nerve? If thyroid is not supplied by the ansa cervicalis, fair enough. But then who supplies thyroid? Who supplies thyroid? So remember over here, I guess you must be knowing that C1 separately supplies two separate muscles, GH and TH. Geniohyoid and thyroid. Right over here, H is common for hyoid, geniohyoid and thyroid. Geniohyoid and thyroid. C1 separately, not through the loop, but separately C1 will supply. Individually, separately. Remember that part. Clear? Chalo. Let's do one more question over here. Not average question, not a very, and that will be the last for the day. Tomorrow again we will resume at 10:15. We'll continue from here only. A 10-year-old boy was admitted to the hospital with a sore throat, earache and high fever. Sore throat, earache and fever. Fever, infection, throat and earache. Fine. On examination, he had a severely swollen palatine tonsils. So obviously, age and fine. What nerve carries the sensory input for most of the patient symptoms? He is having tonsillitis, he is having sore throat, that is a painful symptom. Earache is a painful symptom. Fever is a reflexive response. Which nerve is carrying this main symptoms of the patient? D's and D. What is D's and D's? Okay, for this question, yes, very good. Glossopharyngeal nerve is the answer over here. It's a big nerve. It may look very small. The name actually tells the half of the nerve. Glossa is tongue, pharynx is pharynx. And in the pharynx we have the tonsils. Which pharynx we have the tonsils? Oropharynx. Oropharynx is the place which has the palatine tonsils. Fine. So, but glossopharyngeal nerve also forms the nerve known as Jacobson's nerve. Which nerve? Jacobson's nerve. There is a whole tympanic plexus which enters the middle ear. So you have a referred pain from tonsil to the middle ear and vice versa also. Because the ninth nerve is supplying the sensory component inside the oral cavity plus also in the middle ear. Not the external ear, the middle ear. So this patient is having earache as well as sore throat and tonsils. The nerve is glossopharyngeal nerve, which is also a nerve in the tonsillar bed of tonsil, bed of palatine tonsil. This is the nerve. Jacobson's nerve, tympanic plexus on the promontory of the middle ear, which is the medial wall of middle ear facing the inner ear, promontory. The tympanic plexus is over there. That is nothing. Mainly it is, tympanic plexus is mainly ninth nerve and also sympathetics. Because middle ear also has vessels, glands, supply ASOMs, you remember ASOM, CSOM. So you need sympathetic nerves also over there. That is your glossopharyngeal nerve answer, right? So this was a small part, guys. I hope you enjoyed this small session, and again we'll resume tomorrow at 10:15. So tomorrow we have two sessions. At 4:30 we'll be discussing the craniovertebral joints, the atlantos, occipitals and all these. And at 10:15 p.m., this is all PM and PM, we'll be discussing the high MCQs for the head and neck. We'll conclude tomorrow, and day of tomorrow will be probably taken up the neuro part, right? So that's all from my side. Thank you for your time. That's all. Stay safe. Any confusion, any doubt, let us know in the comment box or in the Telegram groups and all. We will be more than happy to sort it out. Thank you for my side.